to another virtual roundtable discussion hosted by ALTIUS Healthcare Consulting Group. The panel will be moderated by our CEO, Stephanie Dorward.
Good afternoon, everyone, or morning, depending on where you're listening from. Thank you so much for joining us today for the ALTIUS Roundtable. I'm really excited to be joined by our law partners, K&L Gates, today to hear more information on some of the changing regulations and compliance updates. As we all know, these compliance updates are hitting us pretty hard, and they're happening consistently. Day to day, week to week, we have new information that's coming to us on how hospitals and healthcare organizations have to respond. Today, I'm very excited to have our partners information. We have both Sarah, Mila, and Leah are going to share information with you in a variety of topics. And those topics are going to include telehealth, as well as what's happening within the nursing home and long-term care front. And we're also going to hear a lot of the funding regulations. I know that we've had a lot of questions from our clients come in on the CARES Act and how you need to respond from a compliance perspective to make sure that you're maximizing either your PPP designated loan and or any of the other funds that you're applying for. So I think this will be great information for you. I'm going to kick this off by sharing some details with you on some things that we've been focusing on. Our clients right now have told us again and again over the last 2 weeks, productivity's hot again. We know that over the last 2 to 3 years, it was sort of a little quiet. There may have been benchmarking and initiatives, but it wasn't as hot of a topic as it is now. Every single conversation that I'm having right now, whether it's with a chief executive officer, a chief financial officer, a chief operating officer, a nursing staff, are focused in on staffing levels. And it's really not so much on the labor management side of things, but more so on workforce realignment. And a lot of the conversations are on workforce optimization. So this is a high priority right now. And it's really focusing in on being proactive about expectations and scenarios for the future. We're helping our clients and many of you right now really identify your necessary staffing needs today. What are you going to need as your volume rebounds in the non-elective areas and all of the elective areas before? And what are you going to need if you have another bound of COVID-19 come through? So we're working through that during it in the future pandemic. And really what we know and what we shared with a lot of you is that the change in paradigm right now requires updated targets, a new approach that's different than anything that you've done before in regards to labor management productivity. And most importantly, your benchmarks and targets need to be realigned with the new normal. The targets that were in place a year ago are not going to be effective as you move into the post-pandemic world, nor are they effective right now. So we're working with all of you to make updates where necessary, adjust targets, adjust benchmarks. So just a few tips as you're working through this is that, right now, take care of your employees first. Regardless of where the situation is, they need to come first. You have to keep them front of mind as you make all decisions. And then utilize your variable budget reports and your ION reports to really identify areas where you may have excess staff on a day-to-day, week-to-week, month-to-month basis, and where you do not have enough staff. So it's really identifying departments that have available hours that you can shift to one place or another. And this is a strategy that's valuable irregardless of whether you're reopening for elective surgeries and or responding to the crisis. You need to understand where you do have excess hours, where you need more people, and where you don't have enough so you can shift those resources. Right now, we're doing a lot of analysis on comparing targets to median, better performing, and best practice comparisons to identify where you may have opportunities in the future. Many of you are really using this opportunity to right size your management staff, to understand what that's going to look like in the future, and to more importantly, understand how you're building out your rehiring plans in response to the furlough. So really look at these based on volume recovery and understand what that may look like. We also encourage you to really look at cross-training non-essential staff to other support areas, identify and review your expected staffing needs based off your appropriate staffing ratios. And if you need help updating your staffing targets and staffing grids, please reach out. We can certainly provide you with that assistance so we can really build out those staffing grids for the new normal in your clinics, as well as all of your ancillary and nursing areas. And then routinely, as you're going through this, review your productivity and staffing reports to ensure that you're taking the steps to maximize your available staffing levels. This is not a situation where you set the targets and sit back. This really needs to be a situation where you set the targets and move forward. And with that, we're going to move into the brunt of our conversation with our partners from K&L Gates. And we're going to start with Sarah Carlins. And she's going to begin to really focus in on sharing some information with you on how to focus in on that. And if you give us a minute, we'll have those slides up and running. And a couple things to keep in mind too, while you're focusing in on things, make sure that as you're adjusting your targets, that you're focusing in on the median better bet performance levels and looking at how those compare to that. All right, so Sarah, you can just go ahead. Brian's going to pull them up, but if you want to start with your first slide as the introduction, we'll get rolling on the information. So we're going to start with the telehealth components. So this is all of the information focused in on the changing regulations. And we're going to start with just an overview of what has happened. And Sarah's going to walk us through that. So Sarah, thank you so much for joining us. And I know that our listeners have mentioned telehealth. It's on everyone's, words. It's on everyone's mouth. Where are we and what can you share with us?
Thank you. Thank you so much, Stephanie. And let me say it's a pleasure to be here with you on this forum. I am Sarah Carlins from the Pittsburgh office of K&L Gates. We have my partners, Leah Richardson is from the Research Triangle Park office, and Mila Risen is from our Miami office. So it's a pleasure to be able to be here together through this technology. So I want to talk a little bit about telehealth, which some of this stuff might be familiar to people, because back, starting in March, really, the government did a lot of things to increase the accessibility of medical service to patients without requiring the in-person interactions for the duration of the public health emergency. And that was done through a number of different things. Many of the things we'll be talking about today have to do with the Section 1135 of the Social Security Act waivers that came out in middle of March, CARES Act, which came out at the end of March, supplemental guidance from sources such as CMS, OIG, OCR, and also CMS. I think we should be on the next slide, please. Also, CMS has come out with 2 interim final rules. Actually, one slide next. There we go. Perfect. Thank you. 2 interim final rules. One was published on March 30th. One was published on April 30th. And we'll take a look more particularly at the changes or additions, additional flexibilities and waivers that came out with the April 30th interim final rule that may be more new to people. But in general, the point is that HHS has expanded access under Medicare for services that previously would not have met coverage conditions for telehealth. And practitioners can now bill Medicare for traditional fee-for-service services when that care is provided via technology that has real-time two-way audio and video capabilities. CMS did come out with guidance that specifically said smartphones were okay for that. We will see in the interim final rule that came out at the end of April that CMS has now gone further and actually allowed certain CPT codes to be billed when it is audio only, and there is not the corresponding video link. One of the biggest things is that the originating site can now be in any setting, including the patient's home. Previous to the flexibilities and waivers, it was that the patient had to be rural or in some cases at home, but associated with end-stage renal disease, something like that. Next slide, please. A couple other highlights that have to do with the expansion of telehealth services. We had an expansion of qualified providers. So under the 1135 waiver, CMS said, okay, out-of-state providers do not any longer have to be licensed in the state in which they are providing services, as long as other certain conditions of validity are met. The one thing to be aware of here is that CMS waiver obviously does not extend to pertinent state licensure requirements. Now, many states, I would say probably the majority of them, although I haven't independently done a 50-state survey, have similar waivers in place. And where there are not waivers in place, there are, in addition to waivers sometimes as well, relaxed requirements for emergency credentialing, licensing, stuff like that. So just be aware that of the state options as well. I mean, the state regulations as well. The other thing that was done in the expansion of services is services that were not traditionally thought of as services that could be provided via telehealth, such as neonatal care, ED visits, PT and OT services. These kinds of services are now included in what can be treated and billed for in telehealth. Next slide, please. In addition to the telehealth services, which are a list of services that are telehealth, there are other virtual services that can be offered, which constitute remote patient monitoring that are not considered, again, quote unquote, telehealth services, but that are furnished through telecommunication that CMS and HHS are encouraging people to take advantage of. And this is just an example of some of them. Remote interpretation of diagnostic tests, virtual check-ins, e-visits. Again, we're seeing the broadening, the availability of remote patient monitoring to practitioners such as PTs and OTs, and we'll see that again when we look at more specifically changes that happened on April 30th for that interim final rule. So the workforce flexibilities, for example, the regulation regarding Incident 2 services, where physicians and advanced practice professionals previously had to be in the same location as the patient. Now they're allowing that sort of supervision to happen via interactive communication technologies. Next slide, please. So I just want to touch on this because this sort of goes hand in hand with the broadening of the telehealth options. The Office of Civil Rights came out with some guidance saying that related to these new telehealth remote communications, which may not be HIPAA compliant, they would not impose penalties for sort of trying to use these things in good faith through means that, again, previously, would not be HIPAA compliant. They also provided a list of vendors that would likely be agreeable to entering into a business associate agreement with a covered entity and certify as to HIPAA compliance if the provider sought that sort of additional reassurance. HIPAA, there are other HIPAA enforcement discretion guidelines out there, but I'm just talking about the one that's the things that are related specifically to telehealth. Next slide, please. So let's turn to the April 30th interim final rule from CMS, which expanded some of the telehealth flexibilities and waivers. So first, it specifically expanded the types of practitioners who can bill for telehealth services and included those physical therapists and speech language pathologists and other professional service providers who were previously ineligible for billing for telehealth. They also, and this was something that was important to many people, they relaxed the requirements mandating that two-way audio-video capability technology to allow for certain specified services to be provided via audio-only technology. And there is a list of that in the April 30th CMS summary and also in the rule itself. If anybody needs that or has trouble finding that, obviously the guidance and the rule, it can be difficult to access. The rule is just so big. Just ping me and I can help you get to that if you need it. Next slide, please. The other two additional things here that CMS included in the April 30th interim final rule, the level selection for office and outpatient E&M services. They clarified that the typical times for purposes of the level selection would be the times that are listed in the CPT code descriptor. That is different from what they said in the March 30th rule, and there was some confusion. So that's the latest guidance on that. Also, CMS, because related specifically to treating COVID patients, they said that they would allow remote patient monitoring to be reported to Medicare for time periods that are fewer than the 16 days of 30 days, but not less than 2 days. Again, for purposes of treating those people who have COVID infections, recognizing that that time period rule no longer made sense without some flexibility, because some people were getting better sooner than others. Next slide, please. Okay, and this is also a pretty technical thing. They increased payment rates for certain CPT codes to reflect that in the reality today, there were certain audio-only services that are now happening just via phone that are actually really what should qualify as office outpatient Medicare telehealth visits. And so they said we're gonna increase those payment rates accordingly. And there are just a couple of CPT codes noted in there. Finally, and I think this is important for people to be aware of, they said that they recognize that as long as this goes on, or whatever the future looks like, they may need to add services to the telehealth list to say these services will now be covered and would be considered okay to do via telehealth. But instead of having to go through the cumbersome regulatory process every time where they have this notice with comment period, they said we're now going to use a sub-regulatory process to modify that list. And it may include even simply posting it on the CMS website. So just to be aware, that there's now sort of a new, not so here it is way for that list to get expanded. So might want to be aware of checking the website or checking CMS guidance on that. Next slide, please. Okay, so before we go to nursing homes, I just wanted to address briefly, because this is something that I think is on everybody's mind, not just regarding telehealth, but regarding all the waivers and flexibilities that we've seen, is what happens when these things expire. So remember, going back briefly for a minute, remember that there were two things that had to have happened before we were able to get these waivers and flexibilities. Number one, the president had to declare a national emergency, which happened in mid-March. And number two, the secretary had to declare a public health emergency, which he did at the end of January, and which he just renewed, I believe, April 26th, I think it was. And so with those two declarations, we then have we're able to start the regulatory process to have these expansions. These waivers depend on the continued effectiveness of the president's and the secretary's designations, and they would expire when either one of those would terminate, or 60 days from the date a waiver is first published or modified. Note also that the secretary can extend waivers for 60-day periods. So we can't predict, right, when the waivers will end, or if there'll be regulatory or statutory changes that will make any of them permanent, whether there will be a sort of grace period, extended to providers and entities in order to return to sort of pre-COVID operations. But I think one of the things that you can do now to sort of be thinking about that is to be thinking about it and to begin taking steps to prepare. So for example, it would be important to maintain an inventory, be aware of the waivers and the flexibilities that you are currently taking advantage of, and start to think about what changes you will need to make to roll them back. Now, in the example of telehealth, it may be that you've made changes to billing systems and to services being provided, obviously via telehealth. And what are you going to have to do to return to sort of a everybody can do telehealth for everything environment? The other thing, are you using practitioners who are operating under some sort of a license flexibility? And again, in many states, it's now much easier to get a license. There's expedited processes. So it may be that if you think that you're going to need to continue to rely on those practitioners, maybe you start thinking about, well, let's get them fully licensed now. And again, it's important to be aware. I'm sort of focusing on the federal stuff, but it's important to be aware what you have taken advantage of that your state individually may have extended to you. So with that, because we have so much good stuff to talk about today, I want to end. That's just a brief overview on the telehealth stuff. Again, anybody with particular questions, please feel free to reach out to me individually, but I'll now turn it over to Mila to discuss post-acute care.
Okay, great. Thank you, Sarah. Like Sarah mentioned, I'm going to be focusing today on nursing homes and where are nursing homes in the middle of the COVID environment. Next slide, please. One of the first slides to really, let me first step back and just go through the agenda for the brief presentation. Is we're going to just talk about statistics, which are changing constantly, some recent reporting guidance that was issued that's required, surveying that's going on, some guidance, liability that we're seeing out there in terms of different lawsuits, and then immunity. And then what are some takeaways to think about that Sarah gave some very good takeaways on the waiver side. What are some takeaways on the nursing home side? So that's something we're going to talk about. So first off, on the nursing home side, in terms of statistics, that is an ever-changing front, as many of you know who are in the nursing home space or actually even watching the media. On the federal side, as of a week ago, it looks like there are approximately 10,000 deaths associated with the virus in nursing homes, and 5,000 of those are related to New York and New Jersey. However, the numbers have consistently changed and obviously increased over time. And one of the things we're going to talk about is the actual reporting that's been put in place by CMS to have information go to CDC, so there's a clear number of information that's being flowed up on the federal side. On the state side, the numbers have varied depending on the state. Some states, interestingly, like Virginia and North Carolina, 60% of the deaths are related to long-term care facilities in Virginia, and 59% in North Carolina, tied to nursing homes and other long-term care facilities. So the rate is very high. In Pennsylvania, for instance, there's been 3,800 deaths, and more than 2/3 are residents of different care homes. So we can see that obviously with a lot of the states have been impacted. The area that really is being hit is a nursing home environment. Unfortunately, by the end of May, we're going to be able to publicly see when CDC or CMS, whoever's posting this information, will be able to have a lot of data points for the nursing homes consistently around the country. Because what's happened is on the state side is the information over time has been not in a uniform format throughout the states, and some of the information has only recently come available in the past few weeks. So it'll be helpful now to get this information across the board. And the states that I mentioned are not unusual or unusually high. Like, for instance, Texas has 47% of the state is related to COVID in the long-term care facility. So it's a consistent pattern for the states that have been impacted. Next slide. And so recently, as I had mentioned, is that there's new reporting requirements for nursing homes, and that came out in the interim final rule. And it's reporting both within the up to the CDC and certain information that has to be reported to the CDC. And some of the information, obviously, if you're nursing home, you're very familiar with this, but it talks about total deaths and deaths among residents and staff. So it's going also to the staff piece too. It talks a lot about the supplies, the equipment, reporting on staff shortages, which ties into what Stephanie said at the beginning of the call about the number of people you have and how many people you need. So that's something that's relevant that's going to need to be identified and then reported. And then also the suspected and confirmed cases among the residents and staff, including the people previously treated. So that is the reporting. Then there's also separate reporting requirements that have to go to the residents within the nursing homes and their representatives. And there's specific times and triggers for that to happen. That's in the interim final rule. There also is a Q&A that was put out by CMS on this topic to ask some questions. Two of the questions I thought were relevant are do you have to inform all residents, even if they're not impacted by one of the cases? And the answer is yes. And then also, if there's a death in the hospital for one of the patients, does that need to be reported? And the answer was yes. So they're clearly thinking of a lot of the different scenarios to make sure the statistics are being reported up consistently. Also, in connection with this rule, there was a revised focus survey process for nursing homes that incorporated this recent change. So the regulation is now incorporated in the focus survey for nursing homes, and we're going to touch on the surveying process in a minute, but that's already been in place. That's already been incorporated. Next slide, please. So switching to the surveying process, which I think is going to be increased recently, is that there has been funding. $81 million has been set aside for the surveying of the nursing homes. There has continued to be guidance in this area. There was early guidance in early March and then late March, talking about the need for the focus surveys in the areas of infection control, complaints, and also self-assessments, which we're going to talk about at the end of the call. And there continues to be guidance recently that was discussed about the surveying that I just mentioned to you. There was a revised tool for the focus survey that included the reporting we just talked about, but there is a tool that CMS has put out there that's a helpful tool that if someone is doing a self-assessment, that's the tool that would be used by the surveyors for these focused reviews of the nursing homes. And so if someone wanted to proactively do that, that would be, the tools are available on the CMS website. And if you have any questions, you could definitely reach out to us. Some of the findings for some of the early surveys, I thought I would just read to you because I thought they were interesting, is that, and this was early April, is that it found that 36% of the facilities inspected did not follow proper hand hygiene, and 25% failed to demonstrate proper use of protective equipment. So those are just some of the initial findings for initial ones, but it is out there in terms of the continued need that there's going to be the surveying out there. Next slide, please. In terms of guidance, there has been a whole lot of guidance that's come out over the time of the COVID related to nursing homes, and it's been changing. Because we've been writing publication and alerts related to nursing homes since the beginning of March and in April. If someone wants those guidance documents, please let us know. But what we've done is that we've kind of tracked the changes, and you'll see sort of a progression in terms of the advice that's been given by CMS and CDC on this topic. The guidance has ranged from infection control to the restriction on visitors, to also transfers. There is guidance in a number of the documents from CMS and the rule, actually, concerning the transfers and how transfers will work between whether or not it's between two nursing homes, whether it's between a hospital and a nursing home. And so there is guidance out there on that, which is important to be factoring in too. And then also there is some guidance from the different states, depending on your state, in terms of toolkits and what's expected of nursing homes in addition to the federal guidance. There actually was a checklist that was issued just yesterday on the CMS website. That's 74 pages that goes through the different states and some of the things they've done on a whole range of topics. And some of that is very interesting, and it looks like there's access to a lot of that information via the website. So we would encourage someone, if they're looking to do the self-assessment, to maybe definitely look at that document and to be familiar with all the recent guidance that's out there. And next slide, please. In terms of liability, not surprising that this is an area that's going to see some litigation. Is that recently there was a wrongful death suit that was titled Wrongful Death and Damages out in Washington that was filed against multiple defendants arising from some of the earlier outbreaks in one of the facilities in Washington. Also, the Pennsylvania Attorney General made an announcement that it had opened, quote, several criminal investigations into the nursing facilities, and also called the Pennsylvanians to report suspected cases of neglect, which is interesting. On the flip side of that is that there is the immunity in a number of states for nursing homes and for workers. And it really depends on the state as to the whether or not there is the immunity and the scope of the immunity. New York did put something in place both for the facilities and the workers, and it looks like there's a number of states that are proposing different legislation on the topics. And some of them already actually have some in place, depending on what state you're in, if it's the workers, the facility, or both that are being considered. So next slide, please. And the last slide is just some takeaways, which is where we are now and what can we think about doing with everything. And I think one of the first is an information tracker to really, on a daily basis at minimum, be tracking the information and guidance for the nursing homes that's coming out from the various areas, whether it's the state, whether it's the CMS, CDC. But it's critical. The standards are changing, and to have someone who can be on point to get this information. Also, the policies, to examine your current policies, your current protocols in comparison to this information and see what needs to be changed, and to make sure everyone's consistently following the new guidance that's out there. Also, mock surveys and self-assessments, whether you have someone on the outside come in and do a survey for the facility, or just self-assessments with the surveys that are available, but proactively think about these issues within your facilities. And if there's issues identified, start working through them and work through and develop a corrective action so you're tackling them early on if the virus hasn't hit you. And if it has hit you, then what can you do to improve certain areas to contain it? So those are kind of the highlights of the presentation today. And I definitely feel free to reach out to me afterwards with any questions, if there's any questions on this topic, and also happy to circulate, like I said earlier, about the guidance, sort of a summary of the guidance document that KL did for the nursing homes, if that's something that's interesting too.
Thank you so much, Mila. Fantastic information. And I do recommend to all administrators, managers, directors of nursing homes and long-term care facilities to take the advice of doing a mock survey or self-assessment if you have not done one yet. As this progresses, I do think we're going to see heightened activity levels within lawsuits, as well as heightened activity levels around the compliance components. And it's better to be prepared and make sure that you have your policies in place and that you're taking all the necessary precautions to protect both your staff and your residents before you actually are in a situation that you need to respond. So being proactive, regardless of where you are in the COVID-19 continuum or within the pandemic or what's happening in the future, making sure that you have the policies continuously updated making sure you stay on that. So I think, Mila, that's great advice on the mock survey. And if anyone needs additional information for that, please reach out to either myself or Mila, and we'll make sure that you get all the guidance and the regulations and the updates. So with that, we're going to temporarily shift to all things funding, the CARES Act and some other information and provider relief. And we're joined by Leah Richardson, and she's going to take it away and share all of this exciting and great information. And Leah, we're very pleased to have you join us from K&L Gates today. I know some of our CFOs have been asking us questions on this information, and it's great to connect them with an expert.
Thank you, Stephanie, and thanks to everybody who's listening or who will be listening later on. So yeah, today I'm going to focus on the CARES Act, HHS provider relief funding. There are multiple funding opportunities for healthcare providers in different contexts, and we really could have an all-day webinar to discuss every single one of them, but I'm going to discuss the provider relief funding because it does have strings attached, even though they're not loans. And there have been a lot of questions about the terms and conditions and whether more guidance will be issued. And in some cases, I think some of the terms leave more questions than answers. So the CARES Act and then a statute, the Paycheck Protection and Healthcare Enhancement Act that was promulgated a few weeks ago, which we call CARES Act 3.5, provided a total of $175 billion in relief funding to hospitals and other providers on the front lines of COVID. These funds are intended to support healthcare-related expenses and lost revenue attributable to the COVID crisis, and also to ensure that uninsured Americans can get testing and treatment without having to worry about enormous bills. This is separate from other funding opportunities, including the Medicare Accelerated and Advanced Payment Loan Program, which has been ramped back down because a lot of providers did take advantage of that. It's a loan program, the PPP loans, FEMA reimbursement. There's multiple grant programs related to different types of providers and supporting different types of services. So this is all separate from that. Next slide, please. So I'm going to talk first about the general allocation of $50 billion, which has mostly been distributed, but still being distributed to healthcare providers and suppliers. These allocations have garnered the most questions from clients and anxiety as well. So on April 10th and April 17th, Tranche 1, which was $30 billion, was distributed to providers and suppliers all over the country. It was based on your 2019 Medicare fee-for-service revenue. They based it on this fee-for-service revenue number because it was a way to quickly distribute these funds to providers. It was information that CMS and HHS already had, and so they just distributed it proportional to all the Medicare providers in the country that had fee-for-service revenue in 2019. There was some criticism about that. It left obviously a lot of providers out in the cold, particularly providers that have none or de minimis Medicare fee-for-service billing. A great example of that is children's hospitals. And so Tranche 2 was meant to, in part, equalize that disproportional distribution that happened in Tranche 1. It was another 20 billion. It was distributed based on total net patient revenue. And so if you have mostly Medicare fee-for-service revenue and you've got a very big infusion in Tranche 1, you may have seen very little or no, or will get no funds in Tranche 2. And of course, it's the opposite if you have de minimis Medicare fee-for-service billing. So Tranche 2 is meant to reconcile the Tranche 1 distributions with additional distribution. So cost reporting entities did receive an automatic distribution similar to tranche 1, and it was based on cost reports that HHS and CMS already had. That started on April 24th. Non-cost reporting entities have to go on to the general allocation provider portal and apply for additional funding, and it's being distributed on a rolling basis. Next slide, please. So to be eligible for the general distribution, recipients must have billed Medicare in 2019, have provided after January 31st diagnosis, testing, and care for individuals with possible or actual cases of COVID. And they clarified when they say possible cases of COVID, they really mean any patient, which makes that term a bit non-meaningful. I think they realized that by not clarifying that, they were going to leave a lot of providers kind of perhaps thinking they were ineligible. You can't be terminated from participation in Medicare or precluded from receiving Medicare Advantage or Part D. You can't be excluded from federal health care programs or have had your Medicare billing privileges revoked currently. Next slide. So the recipients receiving tranche 1 and tranche 2 funds have to attest to compliance with terms and conditions. It was initially a 30-day turnaround. They've extended that deadline to within 45 days of receiving the funds. You have to attest to compliance, or you can go on the portal and return the funds. And we have had clients do that for various reasons. If you keep the funds and don't go on to the portals and attest, you will have deemed to have attested to compliance and you'll be held to those terms and conditions. For non-cost reporting entities that didn't receive an automatic tranche 2 payment, you have to attest to the terms and conditions for tranche 1 in order to complete your application for tranche 2. Similarly, cost reporting entities that actually did receive an infusion automatically have to go onto the portal and verify all their information. So even they have to have attested to tranche 1 funds. And then of course, in order to apply for tranche 2 funds, you generally have to have received tranche 1 funds. Otherwise, it's not going to let you continue with the application. Next slide. So like I said, all providers that receive tranche 2 funds or are applying for tranche 2 funds must upload certain financial data to the general distribution portal, including gross receipts, sales or program service revenue is submitted on your federal income tax return. For those entities that are nonprofits or governmental entities, you can use your Form 990 or your audited financial statements for state entities. You have to provide estimated revenue losses for March and April of this year related to COVID. That is not a requirement to receive the funds. You don't have to have had lost revenue. They are collecting information about lost revenue, and we'll talk about more about permitted uses that intersects with lost revenue. You have to provide your federally filed income tax return associated with your TIN. And then you have to list all the TINs that of subsidiaries that have received funds but that don't file separate tax returns or have rolled up into the parent tax return or subs that are whose TINs are rolled up into your Form 990 or your financial statements. So next slide. So the distributions are being made on a TIN basis. That is causing some anxiety for entities that have TINs that are related to changes of ownership or other restructuring. You also have to report PTANs on the portals, and there are issues with non-operational TINs and PTANs. So it's created some complexities for attestations for entities that have complicated corporate structures. So in terms of the portal, Any person in the organization can complete the forms. HHS recommends the CFO or another accounting professional. HHS has stated it's not going to share revenue data with other entities in or outside the government, except for prescribed by law. For Tranche 2, HHS has stated that it's processing applications in batches every Wednesday at noon. Funds are not distributed on a first come, first served basis, and every provider is going to get their equal consideration. And Tranche 2 funds are expected to be distributed within 10 days of a submission. Next slide. So before we get into the terms and conditions, just a few other slides on other allocations. So there was an allocation of $12 billion to high impact area providers. So it's going to 395 hospitals that have provided inpatient care for 100 or more COVID patients through April 10th. This was based on data that was submitted by hospitals, requested and submitted. The hospitals are getting a fixed amount per COVID inpatient admission, plus additional amounts, taking into consideration disproportionate share and uncompensated care payments. This list of 395 hospitals is publicly available on hhs.gov. Next slide, please. There's also a $10 billion allocation for rural providers, RHCs, community health centers. They are going to receive a minimum base payment plus a percentage of their annual expenses for operating costs and lost revenue. Clinical non-hospital sites will receive a minimum of $100,000 plus additional funds based on operating expenses. Rural hospitals and critical access hospitals will receive no less than $1 million. $400 million also went to the Indian Health Service. Next slide, please. There's also, and this could be a separate presentation, but I wanted to at least mention it. There's an uninsured patient program. It's kind of a mini federal health care program that is meant to support healthcare related expenses, testing and treatment for uninsured individuals with COVID-19. So starting May 6th, providers who have provided COVID testing or treatment for uninsured patients on or after February 4th can submit electronic claims. There's an enrollment process you have to go through. The claims will be reimbursed at Medicare rates. And there are terms and conditions for this program similar to the other provider relief funding. The amount of funding has not been specified. It probably will be just as much as needed, depending on how many uninsured folks are being tested and treated. Next slide, please. And then future allocations is still up in the air. There's still $100 billion left between the two CARES Acts. Secretary Azar and FEMA Administrator Gaynor have requested $10 billion specifically for SNFs. CMS has issued data requests from states related to information related to their Medicaid providers. And so we think that's in relation to distributions that are going to be made to Medicaid providers. There's also a possible allocation for dental providers who generally don't bill Medicare. And so there is a lot of funds left, and so there are going to be future allocations, and we're anxiously waiting to see what those will look like. Next slide, please. So the terms and conditions are causing some angst and anxiety. Recipients must attest to compliance in order to retain the funding. Many of the terms are from the two Consolidated Appropriations Acts for fiscal year 2020. There are other terms that indicate the federal government is going to treat these funds much like a federal grant. And in fact, some of the federal grant tracking and financial data regulations are specifically cited in the terms and conditions. There are many terms that where guidance is to further clarify the intent and application of the terms is really needed. And of course, we do believe False Claims Act does apply to these funds. HHS has indicated that there will be significant anti-fraud monitoring and enforcement actions. Next slide. So permitted uses, the terms and conditions specifically say, at least for the general allocation funds, that the recipient has to certify that the payment will only be used to prevent, prepare for, and respond to coronavirus, and that payment shall be used to reimburse recipient for healthcare related expenses or lost revenues attributable to coronavirus. Next slide. So what does that mean? Healthcare expenses attributable to coronavirus. It's unclear whether expenses have to have a direct nexus with COVID. For example, expenses either treating COVID patients or expenses that in order to, protect your healthcare workers, like additional PPE, or if it could have a less direct nexus to COVID. It's unclear at this point. Lost revenue, HHS has said that providers may use any reasonable method to estimate lost revenue for March and April, and regarding reporting in the portal. For example, comparing budgeted revenue over actual, or comparing revenues in 2019 over 2020 revenues. One thing that's still unclear is whether if you are taking the funds to make up for lost revenue, is that the end of the story? Are those funds still going to be subject to the terms and conditions, or can you simply just replace your lost revenue and use it as you would any other operational funding? So a lot of questions there. Next slide, please. There's a lot of guidance in the terms and conditions about prohibited uses. Obviously, you can't double dip, and so the funding can't be used to reimburse for expenses from which you are being reimbursed from other sources. FEMA reimbursement, PPP, grant funding, just to name a few. There's multiple terms and conditions related to other kind of prohibited uses of funds. These are from the Appropriations Acts for fiscal year 2020. They're very common in the grant world and just apply to appropriations generally. So gun control advocacy, lobbying, abortions, embryo research, etc. Next slide. So for recipients receiving more than $150,000 in funding, there will be quarterly reports required. The new FAQs that were released last week indicate that the first reports will be beginning for calendar quarter ending in June. There's still no guidance on the form or context of the report, but HHS specifically did state in the FAQs that they are going to provide additional guidance about the type of documentation expected to be submitted. And the CARES Act does require that information on the amount and the use of the funds will be made publicly available on our website. And so I think folks need to be aware of that when they're accepting the funds and using the funds, that all of that may be out in the world eventually. Next slide. So there's a balance billing requirement. Recipients must certify that they will not seek to collect from the patient out-of-pocket expenses in an amount greater than what the patient would have otherwise been required to pay if the care had been provided by an in-network recipient. And so this applies to actual and presumptive cases of COVID-19. So a presumptive case is a case where a patient's medical record documentation supports a diagnosis, even if there's no positive in vitro diagnostic test. This is causing a lot of angst because, I mean, typically out-of-network providers don't actually know or have a mechanism to know what the in-network cost sharing would be for a patient. Next slide. And so, there's no direct guidance on how to determine in-network rates for this purposes of this requirement, or even when the obligation will end. At some point, providers have to be able to stop doing that. The FAQs instruct recipients to submit claims to the insurers, And they noted that most insurers have publicly committed to reimbursing out-of-network providers at the prevailing in-network rate. I'm not sure that's helpful to knowing what the cost sharing amounts on the patient's end will be. One helpful thing in the FAQs, though, was that it clarified that the requirement is applicable to your independent contractor providers only if those contracted providers have also attested to receiving funding. So if you're a hospital and you have brought in an ED or an anesthesiology group, that group is only going to be held to this requirement if they have their own bucket of funding. Next slide, please. The FAQs that were released last week also gave some information about overpayment and underpayment. Also on the portals, there were additional certification language related to accepting or returning the funds. So first of all, providers who believe they don't have or don't anticipate having lost revenues or increased expenses equal to or in excess of relief payments should return the funds. Providers who believe they've been overpaid in error should reject the funds and submit appropriate revenue documents to facilitate correct payment. Providers who believe they've been underpaid should accept the payment and submit revenue information in order to determine their correct payment. And the way that you calculate this is by taking your total revenue and dividing it by 2.5 trillion and multiplying that by 50 billion. And then that's the amount that you should receive under both tranche 1 and tranche 2 combined based on your total net revenue. And so that's how they're expecting you to compare what you've received versus what you should have received. Next slide. So recipients must be able to document or demonstrate that lost revenues and increased expenses attributable to COVID-19, excluding other expenses and losses that have been reimbursed from other sources, exceed total payments from relief fund. And so that is all about creating this audit trail, creating auditable records to be able to prove up what you have used these funds for. HHS noted that it does not intend to recoup the funds as long as a provider's lost revenue or increased expenses exceed the provider relief funding that they've received. Next slide, please. So, I don't have enough time to go over all the terms and conditions. There were several other ones that I think are also are generating common questions. But so to ensure compliance, I think there's a few things that providers can do. I think they need to carefully look at these terms and conditions to understand what they mean, consult with in-house or outside legal counsel about what those terms and conditions mean for each provider entity in the context of each set of facts. You are required to track the use of the funds and maintain auditable records. Because HHS is treating this very much like a grant funding program, health systems, providers that are commonly accepting HHS grant funds, that will feel very familiar to them, the segregating the funds and tracking and because that is a requirement to accept grant funds. Providers that don't have research programs are going to feel like this is a little bit different for them and are feeling very nervous about it. So we've advised to just segregate these funds if you're concerned about tracking processes that you have in place. And then, of course, you are going to have to record every use of these funds and be able to prove it up to HHS. We also recommend creating a compliance checklist to track each compliance term, outline processes for confirming and maintaining compliance, outlining personnel responsible for auditing and maintaining compliance. We've developed several checklists for multiple clients who really felt like this would be helpful. to their entity to keep track and make sure that they were, doing everything they needed to do. And so, yeah, we've been helping clients to do that. So that's all I have for today. We are advising on these funding programs, as well as others every day. It's a big deal for the healthcare providers out there. And a lot of them are receiving a lot of money. And so happy to have folks reach out to us and we are happy to assist with compliance with these funding programs.
Thank you so much, Leah. That was fantastic information. And I have fielded a couple questions from participants. So if all of our panelists want to jump back on camera, we can sort of have an interactive section for about 5 or 10 minutes, and then we can wrap up.
All right, great.
Thank you all for the great information. I think all of our listeners and future listeners will really find it valuable. And Leah, the first question actually is for you, and I might add on some additional information, but the question relates to the segregation of funds.
Mm-hmm.
So we had a client that stated, we've made the step to put all of our payroll expenses and the employees clocking in and clocking out for COVID-19 related care into another cost center. However,
Mm-hmm.
would you recommend doing the same thing for things such as our expenses of PPE and just making different cost accounting categories and accounts to put all those funds in for audit purposes?
I think when we talk about segregating funds, we're talking about, if you get $100,000 in provider funding, to stick that in an account, and then as you're pulling out of the account to use for X or Y or Z, then you can create the auditable trail. Some folks might be doing that with the employees in the payroll because of the PPP program as well. But I think it all depends on how comfortable entities are with their current, tracking system for just their operating expenses. And some entities are feeling very comfortable that they're creating an audit trail just based on their normal processes. Other clients feel like they're a bit nervous about that. They don't track so carefully where money is going and to what vendor. And so they feel like they want to segregate it. And so it really is going to depend on each entity's how comfortable they are with their current processes. It's not a requirement to segregate funds. I just think for some entities, it's making it easier to track the permitted uses and create that trail. And like I said, folks that regularly receive HHS and NIH grant funds are going to be really familiar with all of that because it's always required when you accept a grant.
I think that's very true for organizations that are used to accepting funds from the government in any shape or form. They're going to have the structures put in place to actually track it appropriately. Yeah. And I think it's some of the smaller organizations that maybe are not used to receiving those funds that may not have the systems in place. So great advice. The next question is going to shift to Sarah, and it's a little bit of a situation I think deals with telehealth. And the question is, we've recently just been able to stand up our physical therapy, occupational therapy, and those types of therapy services in the telehealth environment. And now we're concerned about how long we'll actually be able to provide those through telehealth. Any sense of how long the funding will remain in place for those and the exemptions and what that timeline might look like?
Sorry, I was on mute. Yeah, that's a fantastic question, and wouldn't I love to have a crystal ball to be able to answer that, right? But I think two things. I don't think anybody really has a sense of how long these flexibilities will continue. Number two, I think everybody does have the sense that many of these flexibilities and the expansion that we have seen in telehealth, that will remain post-COVID. because we have sort of seen that we're able to do it. People got up to speed quickly, and we have seen that it has been something that has worked for many elements of our population, perhaps in particular. So while that is not a good answer to that question, right? I don't know that there is a good answer to that question, except to say, be aware that some of these flexibilities will go away, but also know that it's not all going to go away, and it's not all going to go away like next Friday or something, right? So I think that you can have some confidence in your ability to continue with the programs that you have put in place recently for probably some period of time, yet knowing, well, if this is something that does go away, I'm aware that we'll have to go through a process of sort of getting it back to pre-COVID. But again, I don't think one day it's going to be black and tomorrow it's going to be white. I think there will be some reasonable transition periods, hopefully, for those services that do go back, and also a recognition that some of these services can continue to be provided in this sort of expanded telehealth world. So that's what I would say to that today.
And I think, to your point, Sarah, we're going to see an expansion of these services continuing in telehealth. And even though some will, necessarily have to go back to the traditional environment due to the type of care, I think we're going to continue to see the telehealth components. And there is a downloadable file for those of you that are interested. I think Sarah may have referenced it, but if you go to the CMS website, you can actually look for the telehealth services file, and they list all of the codes and all the types of visits that are currently allowed and when the temporary addition was placed and put in place. So you can sort of see, based off of the codes, which ones they now identify as potentially being temporary and which ones are here for the long term. And that gets updated pretty much on a consistent basis. And so you can download that. I don't remember the exact date, but I know it was just updated on April 30th. So on the CMS guide, if you just search for telehealth services, I'm sure it'll pop up, or you can reach out to Sarah and I'm sure she can give you more information as well. Mila, we're going to switch to the nursing home now. And the question was, we feel that we need to do some type of audit or some type of policy restructuring, as you mentioned. Where do you recommend we go for a good source for the checklist that you identified? And Mila, you're muted, so if you can just take it off of mute first.
So sorry about that. I had
That's okay.
over here. Yeah, is that I think that between the document that was just issued today or yesterday has some good information in it. I think that there's also the actual survey, the focus survey that's out there that has all the criteria that CMS would be auditing against. And then I think also, so that the CMS survey itself goes through whether the tag items they're looking at and how they look at it. And then with those surveys, there's also some frequently asked questions that kind of tie into the surveys that I would look at. And then the CDC website also has some very good sort of preparation checklist that it's mostly tied to the CMS, but there's also additional information there. So those would be the first steps. And then also, depending on your state, some states have different toolkits. So you may want to go to the states and see about the toolkits that are there. But we've actually put together something with KNL to do some stuff for the nursing homes, and those were the primary source documents. Also, there are good associations in different states that have put out some, depending on the states and everything, that have put together some tools too. So it really depends on your state and your information, but those would be the primary initial sources I would look to.
Perfect. And I think the next question I have is more of a crystal ball question. I'm not sure that anyone is going to really have the answer to this, but Leah, it deals with the funding that's been allocated so far and the fact that there have been roughly, I think you mentioned 350 hospitals and they quoted that number, that there were 350 hospitals that had more than 100 COVID cases. Do you think there will be additional funding that we can reach back and grab if our cases grow above that 100 number in the future? And you can feel free to say you don't know.
Yeah, that's a good question. I would suspect that that will be the case because I think what we're seeing is, you know, New York and New Jersey are starting to die down. And it was 395 hospitals, and they were, if you look at the list, you know, they're concentrated in kind of big city hotspots. But I think those hotspots are starting to shift to other parts of the country. And, you know, they have not, there's still $100 billion approximately left to distribute. And they probably are being a bit conservative about not running down the full 175 billion until they really get an idea of what's happening. You know, obviously the hot spots and just trying to assist folks keeping their doors open, especially in March and April and May, when even, you know, some providers, it's by choice to not have elective surgeries and to have clinics open. But for some, it's via governor's order. They don't have a choice. And so, you know, I think the initial waves are meant to help keep the doors open. I do think there's a good likelihood that there will be another distribution for further hot spots down the road. Mm-hmm.
Great. We have a few other questions if the three of you have time. Brian's going to field those.
The first question, excuse me, first question is for Sarah. This question comes from Amanda. Sarah, how is the impacting limited English-speaking deaf and hearing impaired patients? More specifically, for the provision of interpretation services, are there any changes concerning over the phone or video remote interpretation? Sarah, you are muted. One second.
I'm sorry. So the question is, how does the expansion of telemedicine affect people who have?
How is it affecting those who are limited English speaking, deaf, or hearing impaired?
Well, I don't know off the top of my head. I mean, I think that obviously many entities and providers are in their expansion of these services trying to maintain the standards that are expected in other areas for non-English speaking, where, you know, for example, you need to make a translator available, where you do have to provide services in an adaptive manner for those who are impaired hearing wise or other. So I think that you know, I have not seen guidance on that specifically from the federal government, but I would say that in practice, to the extent that the provider or the entity has provided the, you know, is doing that stuff anyway, that you ought to be trying to do that via telehealth to the extent that you can.
Thank you. And the next question is for Leah. Leah, could you go over one more time the formula to determine funding amounts?
Yeah, so for the total funding amount, you're supposed to take your total patient revenue that you're reporting for the year, which for most folks is 2018, because a lot of providers have not finalized their financial statements or submitted tax returns for 2019. So for most of providers, it's 2018. Taking that total, dividing it by 2.5 trillion, which is the total patient revenue in the country for 2018, and then multiplying it by 50 billion, which is the pool that is available for general distribution. And if you go to, if you just Google HHS provider relief funding, you're gonna, the hhs.gov website is going to pop up for their provider relief hub. It has all the links there for the different portals. It has all the terms and conditions for the different funding, which are generally the same, but there are some differences. For example, the rural provider funding pool, you do not have to have had Medicare fee-for-service billing in 2019, for example. That's not an eligibility criteria, but they're generally the same. So all of that's going to be on that hub website, including that formula.
Thank you.
Perfect. So that's all we have in questions for today. And just to summarize, for anyone that has additional information, please feel free to reach out to our guest today. Mila, Leah, and Sarah would be very happy to answer any additional information or questions that you have. Their contact information is available on this slide, and feel free to reach out directly to them. If you have questions and you would prefer to reach out to myself or another member of the ALTIUS Healthcare team, please feel free to do that. We'd love to support you, and we'll make sure that we field all of your questions and send them out to our partners at K&L Gates. So Mila, Leah, Sarah, thank you so much for joining us today. It's been a great webinar and presentation and roundtable conversation. I know I learned a lot that I did not know before today, and I'm sure our clients and participants have as well.
Yeah, thanks for having me.
Thank you.
And for the rest
thanks
of
for
our
the opportunity.
Oh, you're welcome. And for everyone else, next week's topic is going to focus on finance and revenue cycle. We will be joined by a representative of Revenue Cycle Solutions. It's going to talk about all of the impact to the revenue cycle from COVID-19 and steps that your organization should be taking in the future to make sure everything's aligned. So please feel free to register early and to join us next week if you're able to do it live. And we'll also be sharing some additional information that we fielded from our clients on how do you adjust your benchmarks for the post-COVID-19 world, and how do you change your budget? In many cases, budgets have been completed and submitted to the board, but it's not even July 1st for the next fiscal year, and you're not going to achieve your budget already. So what do you do? How do you do an interim budget, and what does that look like? So I'll have all of that information for you next week, Thursday at noon. And again, thank you to our partners from K&L Gates. It's been a great afternoon and a great session.
This virtual roundtable discussion was brought to you by ALTIUS Healthcare Consulting Group. For more information about anything you heard on today's roundtable, or to learn about services provided to hospitals and healthcare delivery systems by ALTIUS Healthcare Consulting Group, visit our webpage at www.altiushcg.com. To be able to get updates on future roundtable discussions, please send an email to info, that's INFO, at ALTIUSHCG.com, and let us know that you'd like to be added to our mailing list. Those on our mailing list will be the first to find out about future roundtable discussions. Thank you so much. Have a great day.